Hey guys, we'll get started in about 5 minutes. Thank you so much. We'll be right back. Okay, everybody, we'll go ahead and get started. First of all, thank you so much, everybody, for joining us. You guys are awesome, as always. We really appreciate you taking the time to be here, hang out with us, and kind of putting that time towards your education. I think it'll be a really good session, and we're very excited. As usual, I'll be keeping an eye on the chat the entire time. So if you have a question about anything, we will make sure and write it down and try our best to relay it back to Melody. That way she can, kind of interact with you directly and hopefully help you guys out with some things that you're wondering about. As far as the quiz, let's see.
Same format. It will be given out at the end. There will be 5 multiple choice questions, and as long as you get 4 out of 5 correct, we'll send you that certificate within about a week.
All right. So without further ado, guys, Melody, if you're ready on that end, it is all you.
Hi, everyone. I'm going to be sharing my screen in a little bit. Let's see. Okay, can everyone see this?
No, not yet.
Okay. Let's see.
Oh, there we go. It's coming up now. Let's see.
Okay.
There we go. Perfect.
Yes?
Yes.
Okay. Awesome. So welcome, everybody. Thank you so much to Pre-PAPals for having me. My name is Melody. I'm an urgent care PA. I'm always super humbled that I'm able to do this and kind of just let you guys know about my day in urgent care, what I do, my scope of practice, and things like that. As with anything, I grow as a PA, as a person, with any sort of feedback that you guys have for me about the session, what worked for you, what didn't. So if you have any feedback for me, my contact information is actually at the end of my lecture. If you want to chat for some reason or just want to say hi, also my contact info and my DMs and my emails are there for you. I'm here for you. So let's start. So a little bit about me. I am a first-generation American. My native language is Spanish, and so if you hear a little bit of an accent or some mispronunciations of words, it kind of is more apparent once I am a little bit nervous, but that's the reason why. My native language is Spanish. I grew up in Los Angeles, California, specifically in Mid-City, Los Angeles. So Mid-City, if anyone is familiar, is known for being a rough neighborhood. Its constituents are basically living at or below the federal poverty level, and that was true of my parents and my family as well. So I knew growing up that education was going to be such a big part of my life because it was a way for me to become successful, not only for myself, but for my family, as well as for my community. And so I'll kind of discuss this in a bit, but now I am practicing medicine in the same vicinity of where and community of where I grew up in. And so I'm really grateful about that. So whenever I do a short talk or lecture, Zoom meeting, anything, I always put this little graphic up because I remember being in the same position that you guys were in, attending these conferences and lectures and seeing this person up there lecturing and never really knowing whether I was actually going to become a PA or be in a position where I can impact lives. But you see this little graphic here. Whenever you meet someone successful, you think that their success is often very linear, so from point A to point B, but you never quite know all of the missteps and failures that occur along the way. And you'll kind of get a glimpse of that right now, where my journey to becoming a PA is a little fumbled, and there's a lot of missteps and failures and turns. And so it's just something to always think about. So in terms of my education, I went to UCLA. I majored in biology. I worked full time while I was in undergrad. It was honestly just a way for me to finance my education. And because of that, it took me a little bit longer for me to complete my undergrad. I worked full-time as a medical assistant, as a home health aide and CNA. It wasn't really that I was interested in any of those jobs, or I wasn't really completing them because I eventually wanted to become a PA. It was just because I had the opportunity. My mother was a CNA and home health aide, and so I was able to get that job without any certifications. And so it worked for me at the time. It took me about 5 years to complete my undergrad. And once I was done with that, I wasn't really quite sure what I wanted to do yet. And so I knew that it was going to be in science. And so I learned about the career path that was called clinical laboratory scientist, or formally, or I guess colloquially known as a CLS. So I decided to do a post-bachelor's program in order to get my license as a CLS. It wasn't really so that I can improve my GPA or my science GPA. It was mainly because I wanted to get that license. And once I completed my license, my program at the UCLA program, I got a job at the UCLA Ronald Reagan, as well as the David Geffen School of Medicine, where I was doing a lot of research. The CLS career path, I don't want to downplay it. It was great, but I grew pretty tired of doing research and being in the laboratory all day. And about 1.5 to 2 years in, I grew pretty tired of it. I felt like it was very repetitive and I wasn't really completing, or I didn't really feel like I was impacting lives in the way that I wanted to. And so I completely changed my route there, and I went into public health research. I did an internship at the Centers for Disease Control and Prevention. I was flown out to Atlanta, Georgia. I lived there for a couple of months, and then eventually landed a research position at the CDC. Where I was conducting baseline data in terms of like food deserts and just how your environment promotes your health in general. And so it kind of opened my eyes in terms of medicine and public health. And I got to come in contact and network with a lot of different dual degree clinicians, whether that was MDs who also had a master's of public health, or PAs who also had a master's of public health. And it kind of opened my eyes in terms of that's what I wanted to do eventually. And once I completed my research project, I had the real issue of determining whether I wanted to continue as a public health researcher, or if I wanted to pursue my goal, which was PA school at that point. And so I had to come to a decision. Do I continue with this really cushiony job, but not really completing or going for my goals? Or do I completely risk everything and just go for it? So I think you guys know what happened. I quit my job, actually. I resigned, and then eventually started doing 2 programs concurrently while I was completing my application to PA school. So I did AmeriCorps, which is similar to the Peace Corps. However, it's located within the United States. And so this one was community health based. And so I was stationed at a federally qualified health center where I was doing a lot of translation services. I was doing a lot of case management. You can see my pictures there. I was also doing a lot of education, either about chronic conditions, on how to control your diabetes, but also about the importance of, at the time, that's when Obamacare was being rolled out. And so the importance of being covered with insurance. Concurrently, I was also doing my clinical care extenders program at St. Francis Medical Center in Linwood, California, where I was basically rotating through all of the different hospital floors and gaining experience in that way, and networking with a lot of different clinicians, whether that was MDs, PAs, NPs, and also running their mobile clinic. And so that was a really great experience for me. So I applied to one school, and that was primarily because I was interested in the PA and PH program. At the time, I'm not quite sure if it's true now, but Toro University, California was the first or the only school that was offering that joint dual degree program. And so I put my eggs all in one basket and I just applied to that one school. I wasn't quite sure if I was going to get in, and I figured if I didn't get in this first time, then I would kind of open up and see if there were any other schools that I wanted to apply to. The application to Touro University, California was financed through that fee waiver. And the one tip that I can give you guys is as soon as that is available to you, they kind of run out pretty quickly. And so make sure that you are submitting your application as soon as possible. So I applied to Touro. I got a supplemental application, and that was about $50 that I had to pay in order to submit that. There was 3 additional essays that I had to do. And once I submitted that, I got a formal interview after that. In terms of the interview format, it was about 30 students. It was led by current students. And I didn't know this at the time, but the current student actually has pretty much a good say on whether you're a good potential candidate for becoming a PA. So the biggest tip that I can give you guys is whenever you're on an interview, make sure that you're always acting professional. Of course, be yourself, but know that there are always eyes on you to see how you're interacting with your peers, to see how you're interacting with your potential colleagues soon. And so just kind of keep that in mind. There was a campus tour, so make sure that you are wearing comfortable shoes for that. And then specifically the interview format, there were a couple of different things that we did. So we did multiple mini interviews. There were some scenarios that I had to go through. Specifically, one that I can remember was that I was a clinician and I had to discuss with my patient that I had accidentally given her the wrong laboratory value. And so I had to take ownership of that. I think that's what they were looking for, and just being professional. In any of these scenarios, it's going to be pretty, you're going to be nervous, you're going to be with a lot of anxiety, but know that you're there for a reason, and just kind of keep that in mind. The other thing that we did was a panel and group interview that posed us with an ethical question. So I get a lot of questions about how to answer ethical questions. Primarily, they're not really looking for a right or wrong answer. They're primarily looking to see how you process the ethical question, how you are able to see both sides of the argument, and whether you're able to come up with your own answer and your own idea behind it. The last thing that we did was a short answer and essay. I think we were given about 30 to 40 minutes for that, a prompt, and then after that we were all done. I will say, I think a lot of the time, I will say that Touro, California, I think is probably one of the longest interviews that I've heard. I think some of them only have MMIs or they only have a panel or group, but this was a pretty long interview. So I got in. So it is a joint PA and PH program. The duration is about 33 months, so about 3 years. 1.5 of those years you're in didactic, and then 1.5 of those years are on rotations. So rotations are assigned. You don't really have to seek out your own preceptors, but they can either be within Northern California, which is where Touro University, California is, or they can be in Central California, Southern California, or even out of state. They try their best to keep you in a location where you have a housing available, but sometimes that's not always possible. So housing is basically up to you, and you have to find that. They were pretty good about keeping me in SoCal, which is where my family is from, and so I'm happy about that. In terms of rotations, I had 9 in total. So there were 4 primary care rotations, pediatrics, outpatient, internal medicine. I had 1 surgery rotation. I had 1 emergency medicine and 2 electives. My electives were dermatology and plastic surgery. I thought that I wanted to do surgery, but that kind of changed once I was on rotations. I also had 1 public health rotation where I was in Bolivia for 6 weeks, and I was actually in that, so you kind of see some pictures here. at Centro Arcoiris, which is a public hospital in Bolivia. And my preceptor was actually a infectious disease specialist. And so it was such an eye-opening experience, and I'm glad that I had that opportunity. So a little bit more about me. I think some of you guys might know me as my Instagram handle, which is at Stethoscopes and Yoga. I started my blog probably about 2 years ago, 2.5 years ago. But really it was to just document my life in medicine, my love for yoga. And I saw it grow really to something that is so big now, and I'm happy and I'm so humbled that people are interested in my journey and what I have to say. And so I'm really thankful for that. I am a co-owner of an aerial yoga studio. You can kind of see that there through that picture. I co-own this yoga studio with my extended family members. I do have a love for photography and writing. You can probably see that on my blog. Besides that, I'm really passionate about teaching others medical Spanish. You see that on my blog as well. I do a lot of collaborations with medical education companies such as Hippo Education. I was running in urgent care boot camp. I also do some board review courses with like MedGeeks and Online Meded. And so I try not to do too many collaborations on there, but I try to maintain that its focus is education. I am also really passionate about being a pre-PA mentor. I run a weekly question and answer forum on the platform that's called Mi Mentor. So any question literally that you may have about my experience, about PA school, about how I finance PA school, literally anything I will answer. So feel free to reach out on that platform as well. So I haven't had the opportunity to have any students shadow me this year, of course, because of COVID, but prior to that, I was having students shadow. In terms of networking and how to first get any shadowing opportunities, utilize social platforms. A lot of the students that I had shadow me, I met online through my blog, either through emails or through conferences. So just make sure that you're utilizing that as much as possible. If you're shadowing me, I do expect you to be about 15 to 20 minutes early, and that's mainly so that you can introduce yourself and also introduce yourself to the rest of the staff. Again, network with other individuals. You're not only there to learn from me, but also from my MAs, my RNs, and my colleagues as well. Soak up as much information as you can. Some of my MAs or RNs are going through PA school, and so it's great to find someone else who's going through that same process. Make sure that you eat a substantial breakfast. It is a long shift, anywhere between 10 to 13 hours sometimes. I sometimes don't really have a set lunch break. I kind of just eat here and there, and then I'm back on the floor. So make sure that you eat something substantial. Wear comfortable shoes. I really don't care if you wear any scrubs or business attire. Just make sure that it looks professional. And then the other thing is, if you feel faint during a procedure, this happened one time with one of my students. I was draining a perirectal abscess, and this person started to feel faint. And so she knew immediately to find the nearest wall and sit down. So hopefully that doesn't happen, but if it does, you know what to do. In terms of how I chose my clinical or my specialty, I actually did not have a clinical rotation in urgent care, but I did have a lot of primary care rotations as well as emergency medicine. I mentioned earlier that I thought that I wanted to go into surgery, but once I was on rotations, it wasn't really my fit. I really didn't like it too much. And so my first year of practice, I worked in family medicine while also working in urgent care. And within about 10 to 11 months after, I decided to make the switch into emergency medicine and urgent care. In the setting of COVID-19, I'm no longer practicing in the ER. I'm not quite sure if I'll go back yet, but for now, I absolutely love urgent care. And you'll kind of see that my urgent care runs very similarly to an ER. So I feel like that fast-paced nature of it is still there. I love my schedule. As you know, urgent care is very heavy on procedures. I do a ton of lacerations and ortho reductions, wound care, foreign body removals. My supervising physician likes to say that we are the jack of all trades because we have to know a little bit about every specialty in medicine because we never quite know what's coming into our door. You'll kind of get a glimpse of the last point here. You have to assess sick versus non-sick. So is this patient stable enough for me to have outpatient treatment, or is this patient sick enough that needs to be transferred out of our urgent care? So we'll discuss that on our second case here. So my urgent care is actually very different from most urgent cares. I work in what's considered a level 2 urgent care that runs very similarly to an ER. So we have 3 different areas in our urgent care. So the first one is our fast track area. And really that's chief complaints that really don't require much of a workup, no labs. The other one is the higher acuity and observation area. So you will see a lot of like chest pain rule outs or like abdominal pain, things that we're ordering labs, things that we're ordering advanced imaging for are seen in the higher acuity and observation area. Right now, of course, in the setting of COVID, we do have a COVID floor and isolation area that I am basically running as a solo clinician for about half of my shift. In terms of colleagues, I work alongside 2 to 3 doctors or PAs, and then we have 1 supervising physician who's always there at all times. In terms of supporting staff, I have my MAs, my LVNs, and my RNs. So the LVNs and RNs are basically the people who are doing the urine catheters, or they're doing any IV placements. And so I'm really grateful that I have that available to me. I do have the availability of stat labs, so I can order CBCs, CMPs, troponins, D-dimers, things like that. But I also have routine labs that aren't necessarily available right away. So like urine and wound cultures, STD screenings, things like that. In terms of imaging, this is where my urgent care really differs. So I think most urgent cares have x-rays available to their patients. However, my urgent care does have a CT scan and ultrasound available. We have radiologists on call if we need to do that. In terms of the patient population, as I mentioned, I am now currently working in Los Angeles. The majority of my patients are Spanish speaking, and I see anyone above the age of 3 months. I do have sometimes I do have scribes available to me. I'm lucky in that sense, but for the most part, when I don't have them, I'm using my Dragon speech recognition, which is basically a talk to text software in order to chart. So this is a very common question that I get. Again, my urgent care is very different. It is open 24/7, holidays, weekends, it really doesn't matter. We are there for you. I do work 3 to 4 shifts a week. And those shifts are generally 10 to 13 hours. I usually work weekends, and honestly, that's by choice because I have a weekend differential, meaning I get paid more on weekends. For now, because of COVID, I'm usually half of my shift is only in the COVID isolation area. So I'm seeing like anyone who's coming in with COVID-like symptoms, upper respiratory infections, and things like that. And then lastly, I see my last patient 30 minutes prior to the end of my shift in order so that I can get out on time. Disclosure. So obviously all of the opinions are my own and they in no way represent my employer or any collaborating companies. All of these cases are real. They are my cases. However, some patient identifiers were changed in order to retain patient confidentiality. So let's get started with my first case study. So this is a 3-year-old female who is otherwise healthy. She's currently being brought in by her mother for a possible left broken elbow. The injury was sustained about 24 hours ago. The mother is really unsure of what happened or unsure of the mechanism of injury. However, she states that probably the patient may have fallen on the left arm while jumping and playing with siblings. She reports that she refuses to use the left arm and holds the upper extremity really close to her body. Yesterday, over-the-counter Tylenol seemed to help, but however, the mother sought out care after no improvement in the range of motion. And like I mentioned, the child is otherwise healthy, no previous surgeries or fractures. So in terms of review of systems, you want to first ask if there's any other symptoms that the patient is feeling. This patient only came in with left elbow pain. Right now, we always have to ask patients whether they were exposed to COVID, if they have any upper respiratory symptoms, or if they have any history of a COVID infection, which the patient didn't. So it's just a left elbow pain in this patient. So in terms of the physical exam, everything looked pretty normal in terms of like the vitals were reviewed, they were normal. There was, she was actually pretty comfortable unless we were trying to manipulate the arm. The respirations were normal, the capillary refill was brisk, the cardiovascular system in terms of rate rhythm were all normal. Whenever someone is coming in with an ortho injury, you always want to assess the joint above and below. So we'll kind of start with that right now. So the left shoulder was normal. There wasn't any gross deformity. There was non-tender to palpation. There was actually full range of motion and full passive range of motion. And then we'll focus on the left wrist and hand for now. So again, pretty normal, no gross deformity, non-tender to palpation, and it was all full active and full passive range of motion. So that was all normal there. The left elbow didn't really show any ecchymosis or bruising. There wasn't any erythema or redness, and there wasn't any swelling. However, the child was holding the left elbow slightly flexed, so you can kind of see this on this picture here, and the forearm was slightly pronated in that location. She was a little bit tender over the anterior lateral radial head there. And whenever I tried to even go close to the elbow, she immediately retracted in pain, was crying. So I didn't really do much of a range of motion. That was deferred because the patient was resisting. So lastly, the other thing that I want to highlight is any patient, especially pediatric patients who are coming in with ortho injuries, you always want to document how the parent is acting, just because this could also be a physical abuse case, but in this case, I didn't really have any concern. So I will open this up. Hopefully you guys are kind of thinking along the same way, but what would be your next step? And if you guys can let me know.
Yes, we absolutely will. There's a small delay. So while we're waiting on those answers to come in, I just wanted to kind of give you an idea of what people are saying. So a lot of cool positive feedback. A lot of people are saying that they're also first generation, so they can really relate to this. One person is saying that's almost their exact career path. So a lot of really excited people to be here.
That's
and
awesome.
yeah, I mean, it's just so cool because with Christmas around the corner, you know, we didn't know what it would be like, but there's almost 200 people here and have been consistently. So yeah, this is really awesome. But yeah, it looks like those answers are coming in now.
Everybody's saying X-ray or scan. Everybody's saying X-ray.
Yes, overwhelming answer is X-ray.
Awesome. So absolutely, you guys are already on the right path. So the differential, of course, the mechanism of injury isn't quite there yet. We're unsure really what happened. She's a little bit tender over her elbow there. And so absolutely we'll get an X-ray. So a left elbow X-ray was ordered. I did order some Tylenol over the counter to be given to this patient based on her weight, primarily because I had an inkling of what the X-ray was going to show and what we needed to do eventually. So this is my patient's left elbow X-ray. Any ideas? Or you guys can just basically say, is it normal? Is it abnormal? And we'll kind of discuss what I'm looking for.
Okay, so we're just waiting for those answers to come in right now.
There's one.
Someone said, if you suspect nursemaids, you can try to reduce it during your exam and then get x-rays. I'm not sure what that means, but other people are
I
saying.
know what that means, but good thinking, yes.
A lot of people are saying abnormal, simple fracture, but it seems like the majority is abnormal fracture.
Okay. So we're thinking this is abnormal for now. So I'll go through what I'm looking for specifically in an x-ray. You guys are only going to be seeing right now just one view. Usually with any ortho injury or with any x-ray, you want to get 2 to 3 views of that joint, because you may not be able to see a fracture on one view, but you will see it on the other views. So for the purposes of this lecture, you're only going to be seeing this one view, which is your lateral view. So first thing you want to see on an elbow x-ray is whether this is an adequate x-ray or not. So we see that on the lateral x-ray. So the first way to assess that is if you see a figure 8, and you can kind of see that. So this is what you're looking for in terms, I'll go through all of these right now, but the lateral x-ray is adequate because we kind of see that figure 8 on this x-ray. We know that it's a good lateral x-ray. The next thing that you're looking for to see if there's an occult fracture is what is called fat pads. So an anterior fat pad, this little black thing right here, is actually normal to see sometimes in an x-ray. However, if it's a bigger, or what we call an anterior sail sign, or a big fat pad here, then that's abnormal. So in this case, I don't really see any abnormality. This is a normal anterior fat pad. In terms of a posterior, you should never see a posterior fat pad. So you can kind of see what you're looking for. It'll be more of a blackish line there. That is always abnormal and always bad. Whenever you see that, you are suspecting an occult fracture. The next thing that you want to look at is for alignment. So you're kind of looking at 2 lines. So one of them is your anterior humeral line, which should be at the anterior of the humerus, and that should basically intersect at the mid 1/3 of the capitellum there. And then the other thing is the radiocapitellar line, which should go through the capitellum here. So you're basically drawing an imaginary line to see if the alignment is adequately there. And in this case, it is. In terms of bones, you're kind of seeing all of the different aspects of it. So the radial head or the radius here. You're also looking at the distal humerus and then the olecranon here, and everything looks normal right now. In the setting of a pediatric elbow, you're also kind of keeping in mind what's called ossification centers that begin to develop as a child grows. So in this case, the capitellum is there, and then I'll kind of go through here, the different ossification centers that are basically developing as the child is growing. So this child is 3 years old, so we don't really expect to see too many of those ossification centers there. Sorry, the child is 3 years old. Sorry about that. Okay, so my interpretation of this x-ray was that it was completely normal. I didn't really see any differences there. I didn't see any misalignment. I didn't see any posterior or anterior or large anterior fat pads. And so my interpretation was that it's a completely normal x-ray. The radiologist, so I usually read my x-rays and then I will wait for the radiologist to also read them, and then we can kind of discuss them if we need to. But the radiologist agreed. So the radial head and neck were intact. The olecranon and condyles were unremarkable. There's no fracture. The alignment is anatomic that we just discussed, and there's no joint effusion or fat pads. And so we both agreed, no acute bony abnormality, there's no fracture, completely normal x-ray. So The next thing was a discussion with the patient's parents. So I discussed that the x-ray ruled out that fracture, but I was clinically suspecting what was called a radial head subluxation or nursemaid's elbow, which I think someone kind of already thought of that. And usually when you are thinking of a nursemaid's elbow, you generally do not get any x-rays. However, this patient had kind of like an interesting story, didn't really have a mechanism of injury that was consistent with a nursemaid's elbow. But also was pretty tender on physical exam. So that's the reason why we got the x-ray in the first place. So basically what we have to do is a reduction or setting that back into place. So a radial head subluxation or nursemaid's elbow is usually occurring when there's a sudden pull of the distal radius here. And it was called nursemaid's elbow because of that reason. A lot of the times the caregiver or pulls on the patient if they're falling or if they're swinging them. And so that's the reason why it's called that. But the pathophysiology is basically that there's this annular ligament here, and that slips over the head of the radius and slides into that radiohumeral joint, and that's where it becomes trapped. And so all of those symptoms of the decreased range of motion are because of that displacement of the annular ligament. So basically what we have to do is a short and quick and fast reduction that is usually pretty successful. And so there's a couple ways to do that. The first thing that you try is actually what's called the hyperpronation technique. So basically, you can kind of see here, this is actually from a YouTube video. There's a couple of YouTube videos that are pretty cool to watch, but this is just a screenshot of them actually doing the procedure. Basically, you're supporting the child's arm at the elbow and you place moderate pressure over the radial head with one finger. And then you grip the distal forearm here and you basically just hyperpronate the arm. You can usually feel a click and the patient, it should be very quick and you hear that click there. If for some reason you're having some problems with that, then we can go to the next technique. And these are all very quick. So the other technique, which is still widely taught, I was taught this when I was going through PA school, but it actually has a higher failure rate. So I actually start with the hyperpronation technique first, and then if that doesn't work, then supination and flexion technique. So again, this is a really good YouTube video. You place your thumb on the prominence of the radial head, and basically you supinate the forearm, and then you flex the elbow. And again, you will often feel that click, and the patient is, it's brief and it's painful, but once you feel that click, it's pretty apparent that the child will start using the upper extremity again. So in this case, we had a successful reduction with the hyperpronation technique. A lot of the times my reductions are being supervised by my supervising physician. And so luckily we had a successful reduction with that technique. And maybe you guys have heard of this, maybe not, but this is called the popsicle sign. Basically, you give the patient a popsicle or a lollipop, and they reach out to you and grab it with the affected limb. I don't think we had popsicles at the time, but we gave her a sticker, and she was able to use the affected arm right away. Usually, when you are doing these reductions, the parents are just like so enthusiastic, and it's because it's a quick fix and you see that the child is no longer having any pain and just really quickly already using the affected limb. Basically, this patient was successfully reduced, and so this patient was discharged home with just some patient education with the parents on how to avoid that. So that was our first case. I will hold off on questions until we get to the end, and then we can kind of go back and forth in terms of if you had any questions about this one. So things to kind of keep in mind is that a lot of the times in urgent care, you are multitasking and seeing multiple patients at the same time. So when I was in family medicine, it was often like you see one patient and then you go on to your next appointment. But in urgent care, to really keep the flow going, you are multitasking. So you have one patient, maybe you're ordering some x-rays, maybe you're ordering some labs, but you move on to the next one. And then you're maybe discharging them, you're also ordering a workup. And so you often are juggling multiple patients at the same time. So just keep that in mind, because at the same time that I was having this left elbow pain, I was also seeing this other patient. So this one is actually pretty interesting. So the chief complaint initially when the patient presented to our urgent care was that she was having right-sided abdominal pain and nausea for 3 days. And that kind of triggers a differential that is completely different to what it ended up being. But you will often find that patients' stories change depending on how you ask things. But once the nurse was rooming the patient, it changed up a bit. So no longer having a right-sided abdominal pain, it was more so right shoulder pain and right lower rib pain for about 3 days. Worse today, of course, and this patient developed nausea in the waiting room, but no vomiting. So again, patients' chief complaints often change based on who's asking the questions, and sometimes it kind of gives them some time to think about it. It's like, oh yeah, maybe I was having this. But once I spoke to the patient, it completely changed, and we were more so on the path of properly diagnosing her. So this is a 75-year-old female who has a history of multiple myeloma, so a blood cancer, plasma cancer, presenting for atraumatic right-sided chest pain with radiation to the right shoulder that's been going on for 3 days. Worse today. The pain is described as sharp and stabbing and exacerbated by breathing. The patient states that she developed nausea and was dry heaving while she was in the waiting room. She has tried over-the-counter ibuprofen with no relief of symptoms and is being followed by hemonc. However, has discontinued chemotherapy about 2 to 3 months ago. She wasn't really quite sure. She says that she's otherwise healthy. She's denying any other chronic condition. So no previous history of a heart attack, no previous history of a pulmonary embolism, no history of diabetes or hyperlipidemia or high cholesterol. No recent surgeries, no recent hospitalizations or immobilizations. However, once I kind of started to think about the differential, I did go through the previous notes. And so that's something that you always want to think about. You know, it will help you in terms of determining, is there really any past medical history that is relevant and important to us? A lot of the times patients will not know that it's important. So if you have previous notes, utilize that. I did see that there was a history of a deep vein thrombosis, which is a blood clot in the right lower extremity. So whenever there is a discrepancy in the triage and nurse chief complaints, I always document that, and that's for medical legal purposes. So there wasn't any current abdominal pain. It was just actually atraumatic right-sided chest pain with radiation to the right shoulder. So in terms of ROS, again, just right-sided chest pain and a little bit of nausea, and no COVID-like symptoms, no sick contacts, and no known exposures to COVID-19, and no history of COVID-19, which is really important as well. In terms of the physical exam, she seemed in moderate distress. She seemed pretty uncomfortable. Besides that, the chest, when I was listening to the lungs, was a little bit decreased breath sounds bilaterally. However, the chest pain was non-reproducible, meaning when I pressed on the chest there, it wasn't producing the pain. And there's a couple of different other ways that you can check for that. There's like truncal rotation, there's just pressing on it, but it was non-reproducible. In terms of her lower extremities, there wasn't any swelling and there wasn't any calf tenderness. Everything else was pretty normal, but she looked like she was in a lot of pain. So what are the next steps that you would do for someone that's coming in with right-sided chest pain?
All right, we'll give those to you as soon as they come in. But while we're waiting, props to Shalini and Diana. Shalini was the one that diagnosed the nursemaid, and then Diana was the one. Yeah, definitely. That's very impressive. And out of all of our responses, Diana was the one person that said that the x-ray looked normal. Everybody else.
Awesome. That's great.
But let's see. So we have answers coming in now. We see definitely x-rays, labs. Could we see if this was heart attack related? EKG, rib x-ray, troponin. Yeah, that seems to be, it seems to be repeating: chest x-ray, troponin, labs in general, EKG.
Perfect. So you guys are on the right thinking here. So absolutely, EKG for anyone, even if it's right-sided chest pain, especially anyone at that age, EKG is the one thing that you want to order. A chest x-ray seemed like a great idea as well. And then we'll kind of discuss labs. I kind of held off on labs because I had a high clinical suspicion that it was something else. And we'll discuss that in a bit. So first thing is first, EKG. And again, I know that you guys probably, I'm sure some of you guys are familiar with an EKG, but I don't know, just take a guess. Is this normal or abnormal?
Okay, so we're just waiting to see this come in. Let's see. Okay, here they are, and we're seeing 5 abnormals. Someone says looking a bit abnormal, like a little too low. Someone saying it looks normal. We have another normal. So it looks like a 50-50 between abnormal and normal.
Okay, awesome. I'm glad you guys are responding. But so this was actually a normal EKG. When you are thinking about an acute MI or heart attack, you're looking for things that are like ST segment. So along this area, if it's elevated or depressed, also if this T wave is inverted on some of the leads. And so I don't see any of that here. This is normal sinus rhythm. I see a P wave all along coursing through every QRS complex. And so everything was pretty normal there. So the next thing that we do was the chest x-ray. And I'm not quite sure how many of you guys have seen a chest x-ray, but we'll kind of discuss what the normal looks like, and then we'll take a look at my patients. So air is going to be black on x-ray. Remember that when you're looking at an x-ray, it's going to be basically flipped around. So on this side here, you are seeing the right side, and then this is the left. And then you're also kind of seeing, you know, all of the bones around there. You're seeing if you see any widening of the heart there, but also seeing the costophrenic angles and then the hemidiaphragms there. So this is a normal x-ray here. Everything looks normal here. And then we start to look at my patients, right? So first things first, you want to make sure it's more so like a structured way of approaching it. But first thing that you want to see, so my thing is lagging, but you can kind of see that it's already abnormal. So costophrenic angle on this side is pretty normal here, but it kind of got lost here on this side, right? You see this kind of haziness here, which you're not really quite sure what it is. This kind of looked like an infiltrate here. I wasn't really quite sure what I was looking at yet. And then we kind of see this somewhat of an ossification. Again, I'm not quite sure what I'm looking at there. And so it was a abnormal x-ray, and that was kind of surprising to me. I wasn't expecting to see what looked like an infiltrate on the x-ray. Again, this is a normal kind of image here, and you can kind of see what you're looking at. The hemidiaphragm is asymmetric, and you see that haziness there. So I actually showed this to my supervising physician, who was, again, like we were both kind of like, oh, that's interesting. It's possibly an infiltrate. Could it be a mass? She does have a history of cancer. And so we waited around for the radiologist. We put in a stat read for this patient. And the radiologist wasn't quite sure either. So there was this asymmetric elevation of the right hemidiaphragm that I discussed with that hazy bibasilar airspace opacities that could possibly be a bibasilar pneumonia versus aspiration with a superimposed component of pulmonary edema. And so they suggested that we correlate clinically. And that's something that radiologists often say, correlate clinically. So again, there was kind of like this muffled diagnosis. We weren't quite sure. I was not really comfortable with the diagnosis of pneumonia, primarily because there wasn't any upper respiratory symptoms along with it, or there weren't any respiratory symptoms along with it. So I didn't want to hedge my bets and say, it's just a pneumonia. Let's discharge her with some antibiotics. And so I had a discussion and consulted with my supervising physician. So the first thing that you want to do is obviously assess risk. This patient is elderly. There is a history of cancer. There's a history of a previous deep vein thrombosis or a blood clot. And she's presenting with atraumatic right-sided, what we call pleuritic chest pain, meaning that it's painful when she's taking a deep breath. The EKG was normal. However, the chest x-ray again was it a possible infiltrate? Was it pneumonia? Was it a mass? Was it pulmonary edema? Was it COVID-19? There's just so many questions along with it. And so I actually did not order any labs because I figured that this was a patient that had a potential to become unstable pretty quickly because I had a high clinical suspicion for pulmonary embolism. So if I would have ordered labs in urgent care and waited 1 to 2 hours, I'm not quite sure if the patient would have honestly lived. So again, that kind of goes back to assessing sick versus non-sick. Is this a patient that I can treat in outpatient urgent care? I do have a CT scan available, but I don't have what's called a CT angiogram. So this patient was actually transferred pretty quickly, got out of the urgent care as soon as possible with that high clinical suspicion that it was a pulmonary embolism. She was transferred to our adjacent ER for a CT angiogram. And the great thing about my urgent care is that we actually share the same EMR. So basically any of the clinicians who are seeing my patient are able to see my note, they're able to see my chest x-ray, they're able to see any labs if I would have ordered them or the EKG. And so they're not really repeating any of the same things. And again, the doctor there also had a high clinical suspicion for pulmonary embolism. I did a pre-arrival note. Basically, I called them, or you can submit this through the EMR, basically that you're sending over this patient and what you are concerned about. So I'm not sure how many of you guys know, but a pulmonary embolism is basically a blood clot that becomes lodged in one of the arteries in the lungs and then blocks blood flow to the lungs. So it usually arises from a deep vein thrombosis in the lower extremities. And if you remember, this patient already had a history of this. And so some of the risk factors, this patient had active cancer, but other risk factors include like recent surgeries or immobilizations and hormone therapy, which is why I asked that in the HPI in the first place. So in terms of the patient outcome, in the emergency room, the doctor who saw her absolutely ordered the CT angiogram, and it revealed a pulmonary embolism, multiple emboli distally in the right lower lobe. And then that consolidation or that thing that we were seeing on the x-ray was possible infarction. They still said versus pneumonia, but it was likely because of the dead tissue or infarction of the lung. And then they did an ultrasound, and it showed an occlusive DVT. And so the last time that I checked up on the patient was admitted and started on anticoagulants. I'm not quite sure if they have been discharged yet, but basically, that was such an interesting case, and it kind of showed you, the higher acuity patients that are coming into our urgent care, but also this need to know and assess, is it something that I can handle in urgent care, or is this patient potentially going to decompensate and become unstable and shouldn't be in urgent care in the first place? So I hope that was an interesting case for you guys. Any questions? No questions? I'm not sure if there's any questions or. I can't hear you.
Hey, can you hear us?
Yes, now, yes.
Really sorry about that.
Sorry about
We have a storm going on over here. We're in Texas right now, so I don't know what's going on. We've had weird technical stuff that never happens to us going on.
If there's
So.
any questions.
Okay, so sorry to keep you hanging on, but yeah, we've amassed quite a few questions. We have some really good ones here.
Awesome.
But let's see. Let me pull them up really quickly. Okay, that's fine. Okay, so taking it back from the top. Somebody was asking about the vitals in the patient in case study 2. They were asking about their pulse ox as well as their BP. And that was actually the one person that prior to seeing the EKG said that it was a pulmonary embolism. So that was,
that's so great. Yeah, I didn't actually put them on the case study, but in the physical exam, they were all normal. So there wasn't any increased or elevated heart rate. The pulse ox, I believe, was at like 98, and blood pressure was normal as well.
Awesome, thank you. And then let's see, somebody else was asking. So someone was asking about apparently Southern California School of Health Sciences PA program is currently on probation standing, and they were wondering if you had heard about that.
I have not heard about that. Oh, which school?
They said Southern California School of Health Sciences PA program.
So Toro University, California is in Northern California. I'm not sure if they're confused, but I don't keep track of any of these specific schools. So I unfortunately don't know if I can answer that.
Yeah, no, sure. Let's see. So earlier when you were talking about your interview process, you mentioned that somebody asked you, or that somebody said that you had a scenario where you gave a patient an incorrect lab result. So they were asking, how did you answer that question?
Yeah, so the first thing was the patient actor was, irate, obviously. And the first thing that I said was, I completely apologize for the mix-up. I'm not quite sure what happened. I take full ownership for that. I wanted to discuss that yours is actually normal. I'm not really sure what happened, but sometimes we do make mistakes, and I apologize for that. Basically, it was a lot of taking ownership and not blaming it on someone else, or blaming it on your staff. But really, sometimes that does happen in clinical practice, and mistakes happen, but it's mainly about owning up to them and being honest with the patient in terms of what happened.
Yeah, that's awesome.
That's an amazing answer.
I'm sure they appreciated your honesty, because I mean, we're real people living in the real world, right? So I feel like people elevate healthcare workers to this like crazy high pedestal, which is understandable, but definitely. So in regard to the first case study, Prisha was asking, could the reduction be done without sedation, or is sedation necessary?
So no sedation whatsoever. If you remember, I did give the patient over-the-counter Tylenol because I knew we were going to be reducing it. So this kind of helped with the pain. The reduction is honestly so quick. It's probably a couple seconds, and you really don't need to sedate these patients.
Wow, that's so interesting. That's the first time I had ever heard of that. So when you mentioned like the popping and clicking sound, I was like, oh my God, like the poor kid. But let's see. So somebody else was asking, can you elaborate why you didn't like surgery?
Absolutely. I think for me, it was the schedule. Sometimes I was in cases for, 6 to 8 hours, and I just always found myself looking at the clock and not really enjoying it, and kind of just wanting to be out of the OR as much as possible. And that's not something that was good. But also, I really didn't feel like I was interested in it. The pre-ops and post-ops were something that I felt were a little bit more tedious for me, and not something that I was really interested in.
Yeah, I mean, that's fair. I understand that those operations can be really long. I know we talked briefly about how I'd seen ortho surgeries, and it is just, I mean, it's a whole nother beast once you get in there and see it for yourself,
Absolutely.
So Nika was asking, this is an interesting question. She said, if your advising physician had a different diagnosis for the patient than yours, would you stick to your diagnosis or feel compelled to agree with the doctor? How would you approach that situation?
So that's actually a really great question. I have had some cases where we don't necessarily agree. Very few, to be honest. But if this was the case, I just had such a high clinical suspicion for it that at the end of the day, you want to make sure that you keep your patient safe. I have had a case where there was a patient who was coming in with abdominal pain for about 5 days. The abdomen was tender on palpation. My attending physician didn't quite think we needed a CT scan, but you have to advocate for your patient if it's definitely something that you are concerned about. In that specific case, it ended up being acute appendicitis, and so she was absolutely happy that I was adamant about getting that CT scan. So sometimes that may happen. Obviously, a lot of the times you guys are going to be on the same page. But if it's something that could potentially harm your patient, be very adamant about keeping your patient safe.
That's an amazing answer. Yeah, absolutely. I mean, I guess when it comes to that kind of situation, you have to check like the ego and all the other things at the door, right? It's the patient's best interest that's always in mind. So that's awesome. Let's see. Someone's asking, based on the experience you have with your supervising physician, would you say there is a significant gap in care or responsibility between the two career paths, or is there a lot of overlap?
I feel like there's a lot of overlap. I will say that a lot of the times my supervising physician will see like the older patients who have a lot of comorbidities. sometimes I am seeing the lower acuity, although I do see higher acuity patients such as this case, but there is a lot of overlap there.
That's great. That's great to hear that, you share that sort of bond, but at the same time you work autonomously from him. So I feel like that's definitely something on a lot of people's minds, is they want to make sure that they're getting into something where they're going to be the provider, and it's more of a relationship rather than working directly under somebody, which I guess is kind of dependent on the supervising physician, but.
Absolutely. I mean, you'll come across on rotations across different supervising physicians who will be on different aspects of that, right? One of them, sometimes they'll be they want to discuss every single case. Sometimes they'll kind of let you work autonomously. And I have been pretty lucky in terms of finding in urgent care and supervising physicians. I have a couple who are all on the same page in terms of PAs practicing at the very top of their scope of practice in terms of autonomy. And if I have a question, if I have anything really, and I need to consult with him or her, then I will. But I feel like very now, 2 years out, I feel pretty autonomous, and I'm seeing all my own patients, unless of course I have a consult to discuss.
That's amazing. Yeah, that's awesome. That's your goals. Yeah. Let's see. So Claire's asking, she just found out she has to retake Orgo, so organic chem, I'm assuming. She said, how does retaking class look on PA school applications?
So I didn't have to retake any classes, but I will say, I think most PA schools are looking at an upward trend. So you may have had a couple of bad grades. You may have had a couple, sometimes like your freshman or sophomore year in undergrad isn't that great. But then towards the end, they're seeing, did you learn a lesson from that? Did you learn a lesson from previously failing or having to withdraw from organic chemistry? And what did you learn from that? And how did you do in the end? I did have to withdraw from, I think it was analytical chemistry at one point. So I had to discuss that with my PA during my PA interview. And basically, I just said I was taking a lot of classes at the time. I wasn't quite sure what I was doing, but I basically took ownership of that, right? I failed, or I withdrew, and then I learned, how to properly assess my time and time management, and really learned how to properly study for chemistry. And I don't think they're really looking at that specific grade. They're really looking at what you learned from that experience.
Well said. Yeah, that definitely lines up with the advice we've heard from other PAs about the similar sort of issue, is that they're going to look at you as a whole. So sometimes you can turn those negative things about your application into, your strengths. You can talk about what you were doing in the meantime, or you can talk about how you've learned and grown from that, like you said.
Let's see. So Katie's asking, fun question. What's your favorite yoga pose? Fellow yogi over here.
Nice.
I love that question. I would have to say that it's a back bend. I usually post this picture quite a lot on my blog or my Instagram page, but it's considered a heart opener. And when you're in that pose, you really don't have time to think about anything else. You're basically in that back bend, and you are present in the moment, and you are focusing on your breath. And so that's the reason why.
Awesome.
Yeah, we follow your Instagram, so we were looking through your pictures and all of your, you were so athletic. I can't imagine doing that kind of stuff. So, by the way, quick plug here. If you guys don't, we'll add a link to her Instagram in the chat, so that if you want to follow her, we highly recommend. There's a lot of cool stuff on her page.
For sure.
Thank you.
Yeah, sure. Let's see. So Christian's asking, what's your typical patient caseload in urgent care?
So typical caseload in terms of numbers, usually I see anywhere between 18 to 20 patients a day or so. During COVID, I have seen upwards of like 60 patients a day, because it's really busy. And honestly, I'm able to do that with the support of my supporting staff, my MAs, but also my scribes. I'm able to see a lot more patients when I have scribes. And so that's the only reason why I've been able to do that. So yeah.
Man, that's, I mean, just in between, co-owning a yoga studio and doing that. I don't know how you've had time to do this with us. So we really appreciate you taking the time to do this. So cool of you. Let's see. So someone is asking, in the second case study, was the patient already on a blood thinner like warfarin due to her history of DVT?
That's actually a great question. I didn't mention that, but she was actually not, for some reason, was not started on any anticoagulants for that history of the DVT. And so that was also something that kind of pushed me towards that direction as well. So that's such a great observation.
Man, yeah, very impressive. Great job. Let's see. Quick question. Someone is asking, how many years have you been practicing as a PA?
2 years, this past October. So like I mentioned, I started off in family medicine and was concurrently doing urgent care shifts at the same time within that same health system. But once I realized that I really liked urgent care and I really liked the fast-paced nature of it and really seeing higher acuity patients, I decided to make that switch over to emergency medicine and urgent care. And so now I feel really comfortable. I did have a very small experience in emergency medicine, and so I feel like that really helped me to find that that comfort with seeing urgent care patients.
Wow,
Incredible.
I actually didn't know that myself. I'm surprised. You seem like you've been practicing for a really long time. Like you seem very experienced.
Very, very.
Oh, thank you.
Yeah.
Yeah. I've had really great support with my supervising physicians, and I'm always super thankful for that.
Oh, that's amazing to hear. Let's see. So someone is asking, so with the first patient, would you suggest a follow-up, or would it just depend on how severe the injury was, and how do follow-ups work in urgent care?
Yeah, so I didn't really set up a like a follow-up. Usually these kind of once we do the reduction, there really isn't much, just that patient education about no longer like pulling at the arm and things like that. In terms of urgent care, again, my urgent care is slightly different. We are part of a larger health system. And so if I need to make a referral, there's certain specialties that I can just refer to without having to go through the primary care doctor. But there's also some that I need to they need to see their primary care doctor before they see a specialist. So if there was a fracture per se in this patient, usually I can just refer them to ortho and they see them within a couple of days because there is that fracture. They saw me in urgent care, and so they have that already. If it's something like, say, cardiology or I can't think of the other ones that are, but if it's a different specialty, then usually you have to arrange a follow-up. And there's nothing that I really do per se for the follow-up with your primary care doctor. It's more so letting them know, there's certain things that I can't do in urgent care. You do need to follow up with your primary care doctor. Sometimes some patients won't necessarily follow your advice, but it's always documented in my notes.
Let's see. And how are we doing on time? We want to make sure we're being respectful of your night.
I'm happy to answer any questions that you guys may have.
Okay, perfect. So maybe 2 or 3 more. Is that okay with you? Okay, awesome. So Nash is asking, what is your work-life balance like?
It's funny that you asked this because if I'm completely honest, it's been really stressful these past couple months. I am seeing majority of COVID patients. I am performing swabs. I'm in very close contact with them. It really is more about making sure that you take the time for yourself. You schedule in your, whatever it may be, right? Anything that you're passionate about, whether it's karate or like running, or for me, it's yoga and working out. And I make sure that I schedule that in. On my days off, if I've had like a consecutive run of shifts, say 3 to 4 shifts in a row, usually that first day off, I'm spent basically just resting. And then after doing the things that I love, of course. But that work-life balance is there for me. I think that my schedule is pretty good at, setting me up for, I have a couple of consecutive shifts, but then I have a row of 3 or 4 days off. So that's the reason why I mentioned, urgent care is great in that sense. You're not working every day, you're working long shifts, but you do have a couple of days off that really help me to do my own sort of mental health and focus on my yoga studio and things like that.
Yeah, and that's a great point to make, is I feel like you have to have something so that you can maintain your sanity when you're dealing with.
Oh, yes.
I imagine how stressful it must be, especially with COVID and all that. Let's see. So somebody was asking if you could choose another specialty, what would it be?
So I've thought about changing specialties. I really do like urgent care, but I think eventually I might specialize in something that's a little bit more procedural based, like dermatology. I love procedures, and so that's the only reason why, but that would probably be it.
Okay. And I think one last question. We usually like to end on something like this, but if you could just comment on your opinion on what you think the future of PA will be like. So where do you see our role in medicine going? How do you see like the salary, work life, or is it going to be more utilized? Just any opinions you have on the future of the profession.
That's such a great question. So I think for now, the course of action that we're seeing is more autonomy, and that's great. Sometimes there is somewhat of a lack of autonomy, mainly for just like recently they just passed a legislation that PAs are able to see Medicare patients or be funded for Medicare visits. And so I only see it improving from here in terms of our autonomy, very similar to say like nurse practitioners, where you don't necessarily need a supervising physician and you don't really need that collaboration, maybe. The other thing is in terms of salary, I mean, I can only see it improving as well. PAs are really highly valued, especially in like emergency medicine and urgent care. I don't really work with a lot of nurse practitioners. So I think in that sense, in my specialty, it's only going to improve and our salary is only going to improve.
Wow, that's awesome. I can't think of a better way to end it, because as pre-PA students, I know everybody here is devoted, and but everybody has that moment of like, God, like what's going to happen in the future? It just seems so unknown, especially with unprecedented things like COVID happening. Like, how is it going to change? So just the fact that you believe that the profession is going to go and just get it even stronger is awesome.
Absolutely. I did want to just kind of share, I think you mentioned that you were going to put up my contact info. Oh gosh. That's basically my contact info. I've been pretty constant in terms of my Instagram handle and my website and my email, but it's all there for you if you need it. Like I mentioned, I absolutely love talking to all of you guys, and thank you so much for this opportunity.
Oh my God.
Well,
yeah. Thank
you
you
so much for joining us and taking the time to answer the questions and creating the presentation. We really appreciate all the time and you joining us. So thank you again.
Yeah, it was an incredible presentation. 200 plus people the whole way through. So everybody really liked it. Like you said, the week of Christmas and the day before Christmas Eve. So we have some very devoted students here.
Right.
But yeah, the whole presentation was awesome. You had great pictures. Your explanations were awesome. When we were going over your pictures, we were both like, oh yeah, there, like zooming in, trying to make it out. But yeah, we really appreciate it. Wish you the best of luck. And yeah, guys, highly recommend you take the opportunity that she's presenting you with here. That's awesome. I can't imagine you can find it anywhere else like this. So yeah, well, thank you so much.
Of course.
Wish you a Merry Christmas.
Yes.
And
Thank you. All right.
take care. Good night.
Bye. Good night.
Thank you. All right, guys, really good session. Thank you so much for joining us. We really appreciate you as always. You guys are awesome. We know Christmas is coming up, so just the fact that you guys are willing to be here and hang out with us, watch this info is like so inspiring. We love to see it. Y'all are awesome. Everything in the chat was incredible. Yeah, guys, stay tuned. We'll let you know what happens. We're definitely going to have a session next week and the following week. We're booked out all the way until like March. So we're going to keep getting you guys those hours. It's really cool experience and all that good stuff. So Olia's working on posting the quiz right now. Sorry if I don't know if y'all have noticed that our setup's a little different. We're working off of a laptop right now, whereas we're used to having like 5 or 6 screens set up. So just bear with us 1 second and we'll get that quiz link set out. But yeah, aside from that, we'll also be hanging out in the chat. If you guys have any questions for us, we'll answer them directly right now. If you think of something later, you can always DM us on Instagram. We try and respond pretty quickly. The quiz will be open for 1 hour. Yes. You just have to do 4 out of 5 correct. So, and there is the link right there.
I just sent the link for the quiz. And then like I mentioned earlier, same format as normal, 5 multiple choice questions. And as long as you get 4 out of 5 correct, you'll receive that certificate within about a week. So you shouldn't receive a certificate any later than December 30th. So we should for sure get them out by December 30th.
All right, guys, if you have any questions for us, just let us know. We'll be hanging out right here. Thank you.
Thank you and happy holidays.
Yeah, take care, guys.